We'll come to the first discussion on thyroid pathologies, and here I'll be discussing euthyroid salty nodule. So, as a preamble to this discussion, when you see a person with a goiter, there are two important things that you have to make in your clinical diagnosis. That is the morphological type of the goiter, whether it's a salty nodule, or whether it's a multinodular goiter, or whether it's a diffuse enlargement. And then also you have to make a clinical diagnosis of the thyroid functional status, whether it's a euthyroid, or whether it's a hyperthyroid, or whether it's a hypothyroid. And also it is important to look at other complications like a tracheal compression or a retrosternal extension. And then whether there are any features suggestive of a malignancy, like a recent rapid enlargement or hoarse voice, or on examination you are feeling a hard gland, or whether there are palpable lymph nodes. And also in a large multinodular hard gland, if you can't feel a carotid, then of course it is indicative of an anaplastic carcinoma. So with that in mind, look at this patient who came to our clinic with this lump on the neck. She was a female and age was 35 years. And according to my discussion which I did on examination of neck lumps, the one initial important thing I told was to see whether it's in the anterior triangle or whether it's in the posterior triangle, and also at an early stage to see whether it's a thyroid, because if it's a thyroid lump, your history and examination will be directed to a thyroid lump. But if it's non-thyroidal, you have to think of the other differential diagnosis of a neck lump. So this patient, well, you can ask few questions like the duration, but you can see that this is a patient with a anterior triangle neck lump. So when we asked to swallow, this lump moved up. So it confirmed that it is a thyroid. And by look, it looks a salty nodule, but of course, examination you may find a multinodular with a dominant nodule on the right lobe. So then we know it's a thyroid, and we took a short history. So it was there for the last 3 months. There's no rapid enlargement. There is no pain. And then we took a history to see the thyroidal status. And the weight was stable, and she didn't have any other features suggestive of hyper or hypothyroidism, like excessive sweating or heat or cold intolerance, any changes in bowel habits, or any problems with the menstrual cycles. So she was clinically euthyroid. So to summarize, so this patient has a salty nodule. Of course, still we have not examined, but she has got a thyroid lump, and clinically the patient is euthyroid. So now we have to examine and further confirm further details. So part of your thyroid examination, some steps will be from behind, but evaluation of the characteristics of the gland and lymph nodes will be from behind. And you lay your both the palms, your fingers, to feel the two lobes, and also you have to move on to the isthmus, and your thumbs will be behind the neck supporting. And also, if you have a nodule which is not very well palpable, you can actually press on the trachea to the opposite side and feel the lump. And in this feeling of the gland, you will identify the morphology, whether it's a diffuse enlargement, or it's a salty nodule, or it's a multinodular enlargement. And also during palpation, of course, again you ask to swallow and you reconfirm it's a thyroid. And then other important things, you feel the consistency of the gland. Are there any hard areas? And also feel for your lymph nodes. And then see whether you can get below the gland. So these are some important things that you look at during your examination. Feeling for the trachea, that you come from forwards and do, and you can feel whether the trachea is in the midline or whether there's any shift. And also whether you can get below the lump. This of course you will do from behind. By this time you have confirmed, but you can reconfirm from your anti-recipient. So this patient, the findings were she had a solitary nodule at the right lobe, and we could get below, and it was a firm lump and it was not tender, and it was approximately about 1 to 2 centimeter in size. Now when you can get below the lump, then it is not necessary to percuss and reconfirm, because you can get very below. But if you have a doubt of the border whether it has a retrosternal extension, you percuss from below upwards to see whether there is any dull area extending below the behind the sternum. And also in your inspection, this type of patients, you can ask to elevate the hands, large goitres, before you even get on to palpation. You may do that first. First you look at the neck. The neck veins may be already distended, and you ask the person to raise the hands and see whether that gets more, or earlier if the veins are not that engorged and suddenly gets engorged, it also indicates there may be a possible retrosternal extension. And feeling for the carotid pulse. Now in a person with a neck lump like this, a small solitary nodule, of course it is not necessary to do that. But if you have a very large multinodular goiter, you have to feel the carotid pulse to see whether it is there. Of course, if it's large, it may be displaced posteriorly, but if you can't feel, it's a bad sign. It may mean that it is a anaplastic carcinoma. And looking for bruise. Again, in this patient with the solitary nodule, it is not very important, because she also does euthyroid possibly, and this most of the time you get this bruise in Graves' disease, and some multinodulars you might find with toxicity, not the euthyroids. But this is how you look for bruise. And then anyway, now clinically we think the person is euthyroid, but we have to examine. By the history we knew, and we have to examine. So one thing is look for a tremor like this, or you can also keep a piece of paper, and then minor tremor may get more obvious by that, and feel for the pulse. So this patient didn't have any tremor, and the pulse rate was 70 beats per minute. So summarizing, a solitary nodule of the right lobe of the thyroid, no tracheal compression, and there was no retrosternal extension, and also physical examination confirms she is euthyroid. And if definitely it is euthyroid, of course looking for eye signs it's not very important, but in the exam for completion purposes, you can ask the examiner, can I look at the eye signs? These eye signs I'll describe more in the discussions that I am doing on thyrotoxicosis, and this is of course looking at the eye movements. Again, in some thyrotoxicosis there may be impairments. So to summarize again, so this is the person we are discussing, right solitary nodule, and she is clinically euthyroid. There's no shifting of the trachea, and also there were no palpable lymph nodes. So initial assessment, since she is euthyroid, a TSHSA alone will be enough, and that was in the normal range. And then a ultrasound scan to confirm the morphology, and also it will tell whether there are any suspicious features in the solitary nodule, any suspicious features of malignancy. And this patient, the radiologist had some doubt. He said it's suspicious, and the person underwent a ultrasound guided FNAC. Now, most of the thyroids, these three forms the basic tools of evaluation. But if you have a patient whom you think hypo or hyperthyroid, it is better to do the T3 and T4 also. But in euthyroid, TSH is good enough because it's the most sensitive out of the three hormones. It changes before the other two. So if it's normal, you can be certain that it is euthyroid. But I'll come to the changes in TSH in my other discussions. An ultrasound, it will tell you the morphology, whether it's a solitary, or it's a multi, or it's a diffuse, or it's a dominant nodule in a multinodular goiter. So it will give all information, and also it will tell whether the nodule or whatever nodules are suspicious. And FNAC is to look at the cytology. So the FNAC, always it's better to do ultrasound guided. And then it came as Bethesda 5. Now Bethesda 5 is suspicious of malignancy. Now this is equivalent to the previous Thai classification 4. These two, the comparison I'll come little later, but anyway now in our hospital it's reported as Bethesda, so it came as Bethesda 5, and also pathologists will give the observation or what their recommendations of Bethesda 5, and this one they said it's highly suspicious of malignancy. So anyway, this type of one it's better to discuss with the patient, with the pathologist. So we thought we will consider this as a more towards a malignant one. So the malignant confirmed one, of course, will be Bethesda 6. But we thought we will consider, and she said this is highly suspicious of papillary carcinoma because, as you know, follicular cannot be diagnosed on FNAC. So she said it's highly suspicious of papillary carcinoma or maybe papillary carcinoma. So we decided the management. So pause the video and just think what is your management plan for this patient. Plan for some time and then just restart the discussion and see whether you have got the answers. The immediate management and also follow-up. So pause and think of both things. Immediate management and follow-up, both. So this patient underwent a total thyroidectomy, which is the current standard in our country for a papillary carcinoma. You do a total thyroidectomy. There are variations of few things in specialized centers and other countries, but for practical purpose, this is the best thing to remember, which will be 100% safe for the patient. Do a total thyroidectomy. And you should know how to prepare for a total thyroidectomy. What preoperative investigations are necessary, and then of course what complications can happen, and then the immediate post-operative care, like when can you feed the patient, when can you mobilize, any investigations that you do after the surgery, and like when you can discharge. So from your ward patients, better to learn this, and it is just a common sense approach. You can for yourself work out things. It's easy. And then the patient was seen in the clinic again. I was talking of a female patient, maybe the husband came to the clinic. So it is a papillary carcinoma. It is a papillary carcinoma. Now, differentiated thyroid cancer, people after total thyroidectomy, they undergo radioiodine ablation, because most of these people, even though we do a total thyroidectomy, there can be some residual tissue in the thyroid bed, and also there can be few micromets. It's possible, but In some patients whom all features are suggestive of more confined disease, there are some centers who do the radioisotope scan first and see whether there's any residual tissue and any mets, and then they do the radioiodine ablation. But in our country, the standard practice is everybody who undergoes a total thyroidectomy for differentiated cancer, they undergo the radioiodine ablation. Now, how to prepare for the radioiodine ablation? The radioiodine ablation is, it's the principle is that the radioiodine is taken up by the thyroid cells and they get destroyed. And we know iodine uptake by thyroid cells is stimulated by TSH. So if you have a high TSH level, the uptake of the iodine by the cells will be better and the ablation will be more effective. So how can we get the TSH high? So now the patient has undergone a total thyroidectomy, and if we don't start on thyroxine, what will happen? The patient will slowly get hypothyroid. It won't happen the next day because your secreted thyroxine hormones will be there in the blood, which has a half-life about 2 weeks. So only after 2 weeks only it gets half, like that it come down slowly to basal levels. And also there is the protein bound stores of thyroxine, so they also will get released. So it generally takes 4 to 6 weeks to patients thyroxine levels to drop to low levels. And when thyroxine levels are dropping to low levels, as the patient is becoming hypothyroid, the TSH will rise. So how we prepare for radioiodine ablation is by not treating the patient with thyroxine after your total thyroidectomy, provided you can do the ablation after 6 weeks. But for practical reasons, most centers doesn't have the access in our country for radioablation after 6 weeks, because people are booked in batches. Radioiodine is brought in and then they are treated. So this you have to discuss with your radioiodine ablation department or the oncologist. And if you think it won't happen in 6 weeks, then you start on thyroxine. You start on thyroxine, and when the date is planned, about 4 to 6 weeks prior, you stop the thyroxine and you get the TSH high. And also get a thyroglobulin assay. Now, because your thyroglobulin levels will tell you whether after total thyroidectomy, there's no point doing it before the surgery because it will be anyway high because your thyroid gland is there. So after the thyroidectomy, you wait again 4 to 6 weeks and you do the thyroglobulin assay. Now, even though this is not absolutely necessary, even the thyroglobulin values will be TSH dependent. So it is better to get the thyroglobulin assay also with TSH stimulation. So the ideal time would be just before the radioablation with the TSH assay, the thyroglobulin assay, because now for radioiodine ablation you have stopped the thyroxine, or after surgery if you can do it within 6 weeks, you don't give the thyroxine post-operatively. So anyway, patient is off thyroxine for 6 weeks for the radioiodine ablation, and there's maximum TSH stimulation. So that is the best time to get the thyroglobulin assay. This is called again the stimulated thyroglobulin test. But if you do unstimulated while the patient is thyroxine, there is not a major problem anyway, but these are good things to remember. And various labs will have their thyroglobulin reports. Generally, if it's below 2 nanograms, that means it is good. And they have various categories like 2 to 5, some risk and over 5 high risk, like that. Your lab will tell you. So even before you do the radioiodine ablation with the thyroglobulin assay, you will know where your patient is there, is standing. So the patient will undergo the radioiodine ablation, which will destroy if there's any residual thyroid tissue and also any micromets. So then after the thyroglobulin therapy, you start the patient on thyroxine. So what are the principles of thyroxine therapy? Now, differentiated thyroid cancer is TSH dependent. The thyroid cancer cells also will grow in the presence of high TSH levels. So after your ablation, you give a high dose of thyroxine so that you keep your TSH in the very low levels, like in the 0.1 level, it is good. Keep in a low level. So you give a dose of thyroxine, so your patient is not toxic, but your TSH are suppressed. But it should be individualized. Say if you have a very elderly patient where you are having a high thyroxine levels and it may have some cardiac effects, then you may treat have the TSH level in the normal range. And also people argue after about 5 years and the thyroglobulins are remaining normal, so not normal, very low levels. So the risk of the disease being active or getting recurrence is low. So some people say after 5 years, you may switch to have a TSH in the normal range rather than having a slightly below normal or in the very low normal limit. So these are discussions, but generally we maintain our patients on a high dose of thyroxine to have the TSH in the suppressed level. Then the further follow-up will be with thyroglobulin assays. And it is important after your radioiodine ablation, wait for about 2 months because the ablation is a slow process. Wait for about 2 months and do a repeat thyroglobulin. And now you have a comparison. You did one prior to ablation and then now you are doing after 2 months, and if it come to very low levels, you are happy. And then further follow-up you do with thyroglobulin assay. You may do one after about 6 months, and then you can do like once a year. So if they remain in the very low levels, of course sometimes you get reports saying that the level is below the sensitivity of this lab, so that is very good, it's very low. But anyway, lab, even if it's a low value, you can judge, the lab will say the risk level. But if you get a rising thyroglobulin when you in your follow-up, that means you have to do a repeat radioiodine ablation. But if they remain the very low levels, that's fine. And again, as I said, when you are doing your repeat thyroglobulin assays, there are two ways to do, either stimulated or unstimulated. Unstimulated is while the patient is on thyroxine to do. Stimulated is that you stop thyroxine and do. But of course, practically we don't do this because we are making the patient so hypothyroid is so uncomfortable. So in the follow-up course, doing this thyroglobulin unstimulated, or when the patient is thyroxine, it's actually it's the way that we do. There's no problem. But your initial one, you have opportunity to do a stimulated thyroglobulin assay then. Anyway, few points of interest is one thing. Now think about this. Now a lot of malignancies, when we diagnose the malignancy, initially we do a staging about the local disease, maybe lymph node, and especially about metastasis. Say like your esophageal or stomach cancer, you do a CT to see whether it is spread to the liver. Most of the malignancies are like, because your treatment will change if there are metastases. But in thyroid cancer, now this patient, if you go back, it's a solitary nodule, patient was euthyroid, scan was suspicious, FNA was highly suspicious of papillary carcinoma, and we embarked on surgery without screening for mets. But after surgery, we did the radioiodine ablation, and on radioablation, of course, with radioablation, you get a thyroid isotope scan also they will give you, and in that you may see whether there were mets. So why is this difference? Why in the differential thyroid cancer, once you diagnose with FNAC, you embark on surgery without bothering to look for mets? Just think why. You will get the answer when you think that the tool for looking for secondaries is the radioiodine scan. The method to look for secondaries radioiodine scan. So just think, there is no point doing the radioiodine scan before the thyroidectomy. Look for mets, because all your radioiodine you give will be taken by the thyroid gland. So you just, even if there are mets, you can't see, so there is no point. So that's why you do the total thyroidectomy. And also, if there are mets, of course very large mets may need some other forms of therapy also, but generally this micromets, your treatment is also by radioiodine ablation. And for radioiodine ablation also, your thyroid has to be out, because if your thyroid is there, you can't treat the mets, because all your iodine will be taken up by the thyroid. So for both the investigation to check for mets to be effective or to be sensitive, and also for your treatment modality of radioiodine ablation to be effective, your thyroid has to be out. So in differential cancer, that's why when we diagnose, we first do the treatment of total thyroidectomy. Anyway, another point that to do the radioiodine ablation, I said you have to get the patient hypothyroid to get a high TSH value. So the efficacy of the treatment is high, but the patient suffers of a severe hypothyroidism. That's another alternative, which is, of course, to my best of knowledge, it's not available in Sri Lanka for the moment. You can use recombinant TSH, artificially made TSH, injections given intramuscular. So you don't stop your thyroxine, but on the day of the radioiodine ablation, you give this TSH injection, which will shoot up your TSH level artificially in your circulation, and then do the test. But studies have shown this elevation of TSH won't be great as the natural by stopping the thyroxine, but of course the patient is very comfortable. So this is just a theoretical point to remember. So when you're coming back to a summary, a person presenting with a solitary nodule of the thyroid, FNAC confirmed a papillary carcinoma, and the treatment was total thyroidectomy, and then thyroglobulin assay to see the basal value. This you do after 6 weeks of thyroxine, and then along with this you do the radioiodine ablation, and then you treat with a high dose of thyroxine to keep the TSH suppressed. And the further follow-up will be by thyroglobulin assays, periodical thyroglobulin assays. Now, this of course we have discussed. Now, Bethesda 5 is highly suspicious, and 6 is confirmed papillary carcinoma. And 6, there's no doubt you do total thyroidectomy. 5, also in a majority, we tend to do the total thyroidectomy. You can discuss with the pathologist and also your patient. Then, now, we just discussed the other categories of FNAC in a solitary thyroid, U and euthyroid. Now, it's important to remember, in a patient with a solitary nodule of the thyroid, in the management, solitary nodule of the thyroid and euthyroid, the primary determinant of the management is the FNAC. The secondary determinant is the size. Why I say the FNAC is the primary determinant is, if there's a problem in the FNAC, either doubt of a malignancy or confirmed malignancy, you operate irrespective of the size. For this source, of course, there are some few sideline discussions which are not put in for your purposes as a medical student. Remembering this is adequate. The primary determinant is the FNAC, and if there's FNAC, there's a problem, either doubt of malignancy or confirmed malignancy, you arrange for a thyroidectomy. Whether it's a lobectomy and total, I'll come to that point a little later. But if FNAC is benign, that is your primary determinant is benign, so primary determinant, there is no indication for surgery, then the secondary determinant come into your decision making, which is the size. So if the size is big with some tracheal compression, you arrange for the surgery. So this is just two principles to remember. Solitary nodule, the primary determinant is the FNAC. First look at the FNAC. If there's some problem in the FNAC, you have to do the surgery. Forget about the size. But FNAC is benign, that is either Bethesda 2 or Thai 2, then look at the size. So that is what you have to keep in mind before getting into this other part of the discussion. Okay. So in the other categories of the FNA, so that's why I said first we are looking at FNA, the primary determinant. We have sorted it out. We do a total thyroidectomy. So then the FNA report, it may be other types. So primary determinant, Thai 1, Bethesda 1. That means it is not informative. So that means you have to repeat the test. Then if the report has come as Thai 2, a Bethesda 2, that means pathologists say it's benign. So it's a colloid goiter. So then you are looking at your secondary determinant of size. If it's large, and especially with complications like a tracheal compression. And tracheal compression clinically you do, and of course you can also confirm by doing a X-ray. So Thai 2 or Bethesda 2, if it is large with compressive features, cosmetic also, of course, yes, if the patient is concerned, you can do. Then what is the surgery you are going to do? You just do a lobectomy only. Because it's benign. You leave the normal lobe. But you look at the histopathology, because very rarely, the histology may come as a malignancy. In which case, of course, you have to go and remove the other lobe also and make it a total thyroidectomy and go through your previous, what I discussed, the radioablation and follow up with thyroglobulin. So Thai 2 or Bethesda 2, if it's large, you do a lobectomy and look at the histology. And in a majority, it will come as a colloid goiter. Then what is the follow-up? Follow-up is, you have to see whether the patient needs thyroxine, and a majority will need. And you wait about 6 weeks. You don't have to rush into treatment. You wait about 6 weeks for things to balance, settle down, do the TSH. If the TSH is rising, and you have a preoperative value, and it is rising, or some people it may have gone above normal, sometimes you start on thyroxine. Otherwise, your other lobe may start enlarging, and annually you do the TSH level. And here you don't have to give a very high dose to suppress, but you have the TSH in the normal, preferably slightly towards the normal level, rather lower level. So that's how you do. Then Thai 3. Now here only these two systems start changing. 1 and 2 both the same. Now Thai 3, the previous classification says the pathologist cannot rule out a follicular carcinoma. There is no confirmation of the diagnosis, it says it may be, may not be. So there again we have to do a thyroid lobectomy and look at the histopathology, and if it comes as a follicular carcinoma, you have to do a total thyroidectomy. But in this, some people say if the risks are high, very large nodules, and also if the patient feels okay, might as well do the total, then even in Thy3, few cases, but we are very selective in this, because majority of this Thy3 who pathology says high, they can't rule out a follicular carcinoma. Majority will come actually as a follicular adenoma. So in those, the lobectomy is enough, because total thyroidectomy has its own complications. But anyway, there are discussion points. But if you remember, if you get a Thy3, you do a lobectomy, look at the histology and proceed. That's fine. If it comes malignant, treat as a malignancy we have discussed above. If it comes as a adenoma benign, follow-up will be just what we discussed for the previous one, where you do a TSH and think whether patient needs thyroxine. Now what is the difference here? What happened? The Thy3 in the Bethesda, they have broken into two categories. That is why after this level, Bethesda is one level above Thy3, because Thai classification, because Thy3 is split into two. Thy4 becomes Bethesda 5 and Thy5 becomes Bethesda 6. Thy4 is highly suspicious and Bethesda 5 is highly suspicious. Thy5 is confirmed malignancy, that is confirmed papillary, and which is Bethesda 6. So in the Bethesda classification, again there is no problem to handle the 5 and 6. 6, there's no question to do total thyroidectomy. 5 again, we tend most of the time do total, but of course you can discuss with the patient, Now in these two, what I'm going to do? Now here, what the pathologist says, it is indeterminate. But in 4, they say it is suspicious of follicular carcinoma. It is suspicious. So Bethesda 4, you do the lobectomy. And Bethesda 3, there is no harm observing. There's no harm observing, but you have to repeat your FNAC. Now, but in clinical practice, lot of clinicians still tend to operate even the Bethesda 3. So ultimately, even pathologists break in these two. Some clinicians, they still treat as one category. So these are all discussion points. So in the exam, if you are told somebody is a Bethesda 3, you can say that according to Bethesda 3 classification, it is not absolutely necessary to operate, because Thai 3 is broken into 3 and 4, and you can observe and do the FNAC again. But if the examiner said Bethesda 4, it is easy for you. Then there is no question that you do the lobectomy. Now, in the cases that we said, we can observe, that is now, that's the Bethesda 3, there's another point. So again, like the previous one we discussed, the primary determinant says you may observe. But of course, if it's a large nodule with a tracheal compression, then you have second point too. So you do the lobectomy again. So you have to play with these two things, the primary determinant and the secondary determinant, which is size. Primary determinant shows some reason to do the thyroidectomy. You have to do it, a total thyroidectomy there. And also primary determinant says Thy3 or Bethesda 4. Again, you have a reason for surgery. Irrespective of the size, you do a lobectomy. But in the Thy2, Bethesda 2, and of course this is your choice, Bethesda 3. If the gland is small, you can observe, but you may observe means that you have to repeat the FNAC after 6 to 12 months time. And if it remains still the colloid size not enlarging, then of course you are another repetition maybe even after 2 years, there's no problem. So I have discussed various things, so it is better to revisit this discussion again and again, and to be familiar with this various types of cytologies. And then what I'm going to do, it's better to get used to the system the hospital use report, either Thai or Bethesda, because if you try to work with both, it is bit of a nuisance. So but anyway, to summarize, in a certain nodule, euthyroid, remember we are talking euthyroid, certain euthyroid. First, the primary determinant, look at the cytology. If it is a level where there is a suspicion or confirmed malignancy, you have to do surgery. If it's just a suspicion, like 3 or here, you do a lobectomy. But if it's a confirmed, highly suspicious or confirmed malignancy, you do a total thyroidectomy. Highly suspicious, you again discuss with the pathologist. But if the primary determinant is benign, Thai 2 or Bethesda 2, then you operate only if the size is big and there's compression. If it's a very small nodule, you may observe. And even if you operate for a large nodule, you just do the lobectomy. And here also the suspicion one, you only do the lobectomy. So what are the other malignancies which may be confirmed by FNA? So there are other things which can be confirmed by FNA. Lymphoma, they may confirm, but sometimes they say just suspicious of a lymphoma. These they can confirm. So medullary carcinoma, again your treatment is a total thyroidectomy, and your follow-up, you give thyroxine. There is no point giving suppressive thyroxine because it's not thyroid cells, so they are not TSH dependent. So the treatment is surgery. Even if you get some recurrence, whatever, it's always surgery. So you do a total thyroidectomy, start on a thyroxine to have your TSH in the normal range, and your follow-up will be with calcitonin levels. They have to remain low. If they rise, you have to see where is this recurrence coming back. You will have to scan the neck and various other parts where it can spread. Anaplastic carcinoma usually happens in long-standing multinodular goitres, and they all of a sudden start enlarging and they feel very hard, and your FNA will confirm. And here you have to discuss with the radiologist. It has a very bad prognosis. Some people think it's better to give radiotherapy first and then operate if possible. Some of course say there's no point operating because it comes back so fast. But if the person has a respiratory, definitely they'll get respiratory obstruction. So if you think you can operate and get a tracheostomy, I think that would be the best, and you can give radiotherapy, but of course very poor prognosis. Lymphoma, you may need the thyroidectomy to also confirm the diagnosis, but of course your treatment, the main treatments will be radiotherapy and chemotherapy. Of course you have to discuss with your the oncologist about this. And then just one point about this follow-up after the differentiated cancer. I said you keep on a very high dose of thyroxine to keep the TSH suppressed. Now and also after total thyroidectomy, by chance, of course you have to always try and preserve your parathyroids, but some people get hypocalcemic, so they need calcium replacements with calcium tablets and also maybe 1-alpha calciferol. But even the people who are having normal calcium levels, when you have your thyroxine levels high in the higher range, there's a chance that there will be a bone demineralization. So even these people, some people think it is better to give some oral calcium supplements. So here we have now finished the discussion on a Salter nodule, which was euthyroid.